So it is 8 o'clock. Good evening, friends. Um, we warmly welcome all of you for today's class. We have invited faculty, Professor Pradeep Chandra Sharma sir. We have Hemant Nodule will be joining us, and Professor Babita Bala from Tirunelveli Medical College will be joining. We also have our senior faculty members, Professor Kanna sir, Professor Nishikant sir, Professor Karnakaran sir, and others who have joined here. Today, we have two important cases for discussion. One is from Himalayan Institute of Medical Sciences, Jollygrant, Dr. Vaibhavi, and the other one is Dr. Deepak Agarwal from St. Isabel's Hospital, who is going to present a case of mass abdomen. So, Dr. Vaibhavi will be presenting first. Dr. Vaibhavi, can you try sharing your PowerPoint? Introduce yourself, your unit chief, your head of the department, and start your presentation.
Yes, sir. Thank you, sir.
Good luck to you, ma'am. Before we start, we wish good luck to all the postgraduates who are giving the clinical examination and both who are present here and in the YouTube channel. Good luck to you for the upcoming exams. Dr. Vaibhavi, retain your first slide. Tell about yourself, your unit chief, your head of the department, and start your presentation.
Yes, sir.
Good luck to you.
Thank you, sir. Good evening, everyone.
Can you switch on your video, Dr. Vaibhavi? We are unable to see you.
Sir, I have video running and screen share both running.
We are able to see your slides, Dr. Vaibhavi. We are unable to see you.
1 second, sir.
Check if something needs to be done.
Yes, sir.
We are definitely able to see your slides well. Yes, now you get it right. Perfect.
Sir.
Again, we are missing your thing. What I will do is you make it not a screen share, like not a full screen mode.
Okay, sir.
Still not, we are unable to see you, Kana. The previous maneuver helped us to see you. Yes, now we are able to see you.
But sir, I don't think I can't see the slide in.
Are you with your laptop?
Sir, I'm on my tab. My laptop actually doesn't have a webcam.
Now, what you can do is, otherwise, you can use your phone to get your video on and keep going with your presentation like this.
Okay, sir.
Are any of your friends in your hostel now nearby?
No, sir. I'm at home.
Okay. If any are colleagues, you can share your PPT. That would be also a good thing to do. Okay, you try by sharing the PPT, then I think it will be better. You are trying to share your screen. That's why you have this problem.
Okay, sir.
Maximum.
So it won't allow me to share it as a PPT.
I think we go ahead with the presentation. We're already 5 minutes down the class.
Yes. Good evening, everyone. My name is Dr. Vaibhavi, and I'm a resident at Himalayan Institute of Medical Sciences in General Surgery. It is my honor and privilege to be presenting clinical case of neck swelling under the guidance of Dr. Hemant Nodule, professor and the head of my department. I will be presenting the case of a 68-year-old gentleman who is a resident of Bijnor, Uttar Pradesh, a farmer by occupation, a Muslim belonging to the upper lower class of the socioeconomic status by the modified Kupuswamy scale. The patient presented to the OPD with the chief complaints of swelling on the right side of neck for the past 4 months, loose stool for the past 3 months, weight loss for the past 2.5 months, and disturbed sleep for the past 2 months. The patient was apparently well 4 months ago when he noticed a swelling on the right side of his neck, which was initially approximately the size of a peanut and gradually increased in size to become the size of a small lemon over these past 4 months. This swelling was not associated with any pain, tenderness, difficulty, or pain during swallowing, voice changes, or a rapid increase in size. He had a history of loose stool for the past 3 months, which was intermittent in nature. He had episodes of 3 to 4 episodes of loose stool in a day, which was not associated with any blood or mucus in the stool, any feeling of abdominal pain, or feeling of incomplete defecation. The patient also had history of significant weight loss over the past 2.5 months, which was noticed by the patient due to loosening of his clothes. This was not associated with any history of fever or loss of appetite. He also had complaints of disturbed sleep over the past 2 months, which was presenting in the form of insomnia. The patient had no history of any increased sweating, palpitations, heat intolerance, hair loss, feeling of anxiety, any tremors, or irritability. There was also no history of increased fatigability, chest pain, cold intolerance, or any mood changes. He did not have any history of any oral ulceration or pain or difficulty in chewing or eating food. There was no history of any chronic cough or blood in sputum. He also did not have any history of any bony pain. There was also no history of any protrusion of eyes, double vision, redness, pain, or difficulty in closing the eyes. For these above complaints, he visited a local doctor and was given some oral medication, but had no improvement in his symptoms. In past history, there was no history of any neck swelling in the past, no history of recurrent loose stool, history of any radiation exposure or radiotherapy, or any tubercular infection in the past. There is also no history of any chronic medication intake. He is a non-diabetic, non-hypertensive, with no history of any other chronic illnesses, no significant surgical history, and no history of any known allergies. Family history. The family of the patient is complete and he has 2 children. There is no history of any thyroid malignancy in the family or any MEN-related cancers. He is a vegetarian by diet, consuming iodized salt. There was no history of smoking, tobacco chewing, alcohol consumption, or use of any other substances of abuse. He has a history of difficulty in sleeping and loose stools, as mentioned in the history of presenting illness, and has normal bladder habits. To summarize the case, I'm presenting the case of a 68-year-old gentleman who presented to the OPD with complaints of gradually progressive swelling on right side of neck for the past 4 months, associated with loose stool, weight loss, and difficulty in sleeping, not associated with any other with features of compression. For the examination, the patient was examined after a full informed consent in a well-lit room. He is conscious, oriented, and sitting comfortably on the chair.
Hello.
Hello.
Hello. What is your conclusion by your history?
Sir, based on the history of the patient, my differential diagnosis is of possible thyroid
What is your
cancer.
conclusion? What is your conclusion by your history? What symptoms he is having?
So he's
What
having
symptoms
symptoms
he
of
is having?
So symptoms of gradually progressive. Hello.
Hello.
So the patient is having symptoms of gradually progressive right side neck swelling for the past 4 months, associated
Okay.
with loose stool for 3 months, weight loss, and difficulty in sleeping, sir.
So what is your conclusion by this history? There is a swelling in the neck along with loose stool, along with weight loss. What is your conclusion?
Sir, my differential diagnosis for this case is that the patient could have a tubercular lymphadenopathy, possibly a thyroid swelling, or some sort of metastatic lymphadenopathy also.
Why tuberculosis lymphadenopathy? Is there is no history of fever?
No, sir, there's no history of
Whether
any
vis-a-vis,
fever, but
then why your
sir, there
diagnosis?
is
Huh?
so, due to the history of a right-sided neck swelling with associated history of weight loss, that is why it is one of my differentials. Tubercular lymphadenopathy is one of the most common causes of cervical lymphadenopathy.
So regarding thyroid
And
condition, which conditions you are
yes, sir.
suspecting in this? Which
So
conditions
regarding, sir, I
by
will
this?
be considering diagnosis of solitary thyroid nodules with features of hyperthyroidism, sir.
Okay.
So
Otherwise,
it could be, sir. Sir, otherwise it could also be a carcinoma of the thyroid.
so which carcinoma?
Um, Sir, it could be a papillary cell carcinoma, sir,
Why
or
papillary carcinoma?
follicular, or sir,
No.
follicular.
History wise. Which carcinoma will present as a diarrhea? Which thyroid conditions will
Um,
present as a diarrhea?
Sir, hyperthyroidism.
Any other thing? Any malignancy of thyroid? Commonest presentation is diarrhea.
Um,
What about medullary carcinoma of thyroid?
yes, sir, medullary carcinoma.
So what is difference in cause of diarrhea due to hyperthyroidism and that from the medullary carcinoma of thyroid?
Sir, in hyperthyroidism, there is a sympathetic stimulation which causes irritability, increased motility of the
Motility.
bowel. Yes, sir. And that is what will lead to diarrhea
And in
in
medullary
that patient.
carcinoma? In medullary carcinoma,
Uh, Sir, in
it's secretory diarrhea.
medullary thyroid, yes, so there is increased calcitonin levels.
It is secretory diarrhea.
Okay, sir.
Dr. Vaibhavi,
Yes, sir.
hi, this is Dr. Pradeep from Dehradun also.
Good evening, sir.
I would like to point out 2 points in your history of presenting illness.
Yes, sir.
Once in your history, you have mentioned the size started like peanut. It was initially of peanut size, and
Yes,
later
sir.
it became small sized lemon.
Yes,
So
sir.
I would suggest you rather than using these terms like peanut and lemon and beans, you should quantify actually. There must be some concrete things. So initially it was 1 centimeter, or half centimeter, or 2 centimeter, which increased over a period of time and became 3 centimeter size or 2 centimeter size. That would be good actually. And
Okay, sir. Yes, sir.
you mentioned the significant weight loss. Actually,
Yes, sir.
your history of presenting illness must be in the patient's own word. And
Yes, sir.
significant weight, a patient doesn't know what is the significant weight, what is insignificant weight loss as far as medical history is concerned, medical history taking is concerned. So my suggestion is to quantify actually this weight loss, whether patient has lost some 10 kgs weight or 5 kgs weight. Okay, that
Yes,
would be
sir.
nice. These 2 things I think you should take. Now the third point is what uh, your history of presenting illness. You have included everything. Now can you summarize it? And third thing I would like to mention, you have said
Yes,
the
sir.
swelling is present on the neck on the right side. You
Yes,
have
sir.
mentioned whether it was in the front of the neck or the side of the neck. More on the right side, that is okay. But you
Yes, sir.
tell that swelling initially was there on the front of the neck, more on the right side, actually on the right side. Because
Okay, sir.
ultimately the organ of concern must be clear as far your history part is concerned, so that you can confine your rest of the history taking and the examination letter. So these
Yes,
three
sir.
things I think you should include. Okay. Now,
Yes,
as
sir.
per your history, as per your history, now the organ of concern as per your history is thyroid or anything else. It could be thyroid.
Thyroid, sir.
It is thyroid. Okay.
Yes, sir.
Is there any doubt?
No, sir.
Yeah. Now the target organ is thyroid. Okay. We will ask differential diagnosis later on, but whatever you have said, it is perfectly fitting into thyroid.
Yes, sir.
Please go ahead.
Examination.
What is the age of your patient?
So he's a 68-year-old male, sir.
Very.
Yes, sir. So he's a
So
68-year-old
kept
male.
the first diagnosis of you kept the first diagnosis of tuberculosis in your patient. Is that the age
Sir,
for the tuberculosis? 68 years?
no, sir. So it is one of my differential diagnosis, but my primary diagnosis is of
No,
a
but that was your first
thyroid, sir.
diagnosis, no? Okay, your primary diagnosis was thyroid. Now
Yes,
tell
sir.
why you were so specific about telling that the patient has got the loose motions.
Sir, loose stool can be presented in cases of hyperthyroidism due to sympathetic stimulation.
Okay.
But
Okay.
it can also be seen as accompanied with the history of weight loss. It can also be seen in conditions such as HIV, in which the patient may have a history of repeated attacks of loose stool. And sir, it can also be seen in conditions in such as so inflammatory bowel conditions, although the age of the patient is not suggestive of the same.
No, you said your target organ is thyroid.
Yes, sir.
So you do not, go around say that it is the HIV and it is the inflammatory bowel disease. You have to relate
Yes,
everything to the thyroid.
yes, sir.
So tell what are the various conditions in the thyroid. One, you said it can be thyrotoxicosis. Second, you said it's a
Yes, sir.
medullary carcinoma. Now tell
Yes, sir.
other conditions which can be there where the thyroid remains as a target organ. Can you correlate something with the medullary carcinoma?
Yes,
Plus
sir.
something? Plus something.
Sir,
What can be the plus thing in the medullary carcinoma?
so it could be MEN syndrome, sir.
Can be MEN. Yeah. So in MEN, if it is there, then which condition
Sir, MEN may also have a parathyroid tumor, in which case the increased calcitonin production could cause diarrhea, sir.
apart from the medullary carcinoma, which can also lead
Sorry,
to the
sir?
diarrhea? Anything in the
Hello?
abdomen along with the thyroid swelling? Hello,
Sir, hello, sir, pheochromocytoma and
can you hear me?
yes, sir.
Yes, yeah, yeah. So you should keep all these things. All these things should be kept in mind,
Yes, sir.
right? Because you are very specifically telling about the loose motions along with that. Okay, apart from the thyroid swelling, so you have to keep all these things in your thinking that these can be the possibilities in this patient.
Yes, sir.
Okay.
For the examination, The patient was
Yeah.
examined in a well-lit room after informed consent. He is conscious, oriented, and sitting comfortably on the chair. The ECOG score of the patient was 0. He has a BMI of 22. The patient appears to look well nourished. The vitals of the patient, he was afebrile with a pulse taken in the right radial artery was 88 beats per minute, which was regular, normal in volume, synchronous, with a normal condition of the vessel wall, no radial or radiofemoral delay. The blood pressure of the patient was 130 by 80 millimeters of mercury in the supine position, which was again taken in the right arm. And he had a respiratory rate of 18 breaths per minute. General physical examination, the patient is well nourished with no signs of pallor, icterosis, cyanosis, clubbing, lymphadenopathy, edema. On conversing with the patient, his voice and speech were normal. So now we move to the local examination, which is the examination of the neck. On inspection, the swelling was noted occupying the midline and more on the right side of the neck. The skin overlying the swelling was normal. The swelling appeared to be a single nodular swelling, approximately 5 centimeters horizontally and 3 centimeters vertically. So it was lying in the carotid and muscular triangles, extending superiorly from the thyroid cartilage to approximately 6 to 7 centimeters above the sternal notch with a visible lower border. And laterally, it extended to the anterior border of the right sternocleidomastoid. Medially, it was 2 to 3 centimeters from the midline. The swelling moved with deglutition and had no visible pulsations, no dilated engorged veins, no scar mark, and it became more prominent on neck extension. The Pemberton test was conducted and was found to be negative. Palpation was done from behind in the sitting position. The findings of the inspection was confirmed. There was no local rise of temperature, no tenderness, and the right lobe of the thyroid gland was involved in the swelling. On palpation, the swelling was found to be approximately 4 by 6 centimeters along the perpendicular directions in the front and right side of the neck. It was of a firm consistency, having a smooth surface, regular and well-defined margins, and moved with deglutition. Extension superiorly was still the thyroid cartilage. Inferiorly, it was still about 6 to 7 centimeters above the sternal notch, and laterally till the right sternocleidomastoid. The swelling was mobile in relation to the deeper structures, and the skin overlying the swelling was also mobile. There was no pulsation or thrill felt. The trachea was central, and there was no lymphadenopathy, and the carotid pulsations were felt bilaterally. No stridor was produced on conducting Cocker's test. On auscultation, there was no bruit found. The eye examination showed no scleral flow, proptosis. Von Graeff sign was negative. There was no lid diffraction. Caffrey sign was absent. Stellwag sign was absent. Mobius sign and Dalrymple signs were also absent. On systemic examination, the cardiovascular system S1, S2 was heard normally with no abnormal sounds or murmurs. Bilateral on the respiratory examination, there was bilateral air entry and the chest expansion was normal. Normal vesicular breath sounds were heard. In the CNS examination, the cranial nerve function was intact. There was no neurological deficit and no tremors. The abdomen was also found to be normal. To summarize my case, a 68-year-old gentleman presented to the OPD with complaints of gradually progressive swelling on the front and right side of neck since the past 4 months, associated with loose stool for 3 months, weight loss for 2.5 months, and difficulty in sleeping for the past 2 months, not associated with other features of compression. On examination, a 6 by 4 centimeter nodular swelling was noticed was felt on the front and right side of the neck, involving the right lobe of the thyroid, having a smooth surface, well-defined margins, firm consistency, and the swelling was mobile with the trachea in the midline. My provisional diagnosis for this case is a solitary thyroid nodule, most likely benign.
Maybe can you go to your, you said this swelling is lateral margin is anterior border of sternocleidomastoid, isn't it? Is that correct?
Yes, sir.
Can you go to your next photograph? Just show the next photograph.
Yes, sir.
Now tell what is the lateral margin of this, what we can see from here. Is it the anterior border of the sternocleidomastoid? Are you sure?
Sir, on examination, it was on the anterior border of the sternocleidomastoid, maybe 0.5 centimeter into it, but it was lying on the anterior border.
And what is the size of your swelling?
So the size of the swelling on palpation was found to be approximately 4 by 6 centimeters. Sir.
So this 4 by 6 centimeters is there.
Yes, sir.
The anterior border of the sternocleidomastoid is just lateral to the midline. There is hardly much of the space is there. So this swelling has to undergo underneath the sternocleidomastoid. You understand that?
Yes, sir.
So it is not the anterior border of the sternocleidomastoid. It is much, even it is going up to the posterior border of the sternocleidomastoid. Right?
Yes, sir.
Then the second thing is that you were telling about the thyroid cartilage, superior border. The thyroid cartilage is a very wide structure.
Yes,
So
sir.
you have to say whether it is the upper border of the thyroid cartilage or whether it is the lower border. Majority of the time we mean the upper border of the thyroid cartilage, but that you have to mention.
Okay,
that it is from the upper border of the thyroid cartilage. Okay.
Yes, sir.
Okay. So what is the relation of this swelling to the sternocleidomastoid?
So the border of the sternocleidomastoid.
The reason for asking that is whatever the size of the thyroid may be there, it may be huge thyroid, you can blindly say, even if you are not examined, that it is deep to the sternocleidomastoid. The thyroid swelling can never come in front of the sternocleidomastoid. Okay.
Yes, sir.
So even if you're not examined, you can blindly say, no, sir, it is deep to the sternocleidomastoid.
Okay, sir.
Vaibhavi.
Yes, sir.
All right.
Hello.
Yeah, that is please. Yeah.
Vaibhavi.
Yes, sir. Good evening,
Can
sir.
you just go to the one slide before? Yeah, whenever you describe any swelling for that matter,
yes,
as
sir.
you start describing, now you have to be little more, because you have to mention now, right side of the neck you are written. Okay. It is better
yes,
that first and foremost is always location. Okay. So right side means, it's a huge territory. Okay. So
yes, sir.
if you are not very sure that it is thyroid swelling, you can even mention right lower neck, absolutely no problem. Or even you can mention anterior triangle, no problem. Sometimes you get midline, so thyroid region is accepted. Don't say thyroid at this stage, thyroid region. Because neck swellings are so interesting. Suppose you have a posterior triangle swelling, means you have a different, you have anterior triangle, different. You have a carotid, carotid body tumor and all, there is a carotid triangle. So that is something which you have to mention. All right. So immediately once you mention swelling noted on the right side of the neck, swelling is present on the right side of the neck. So
Yes, sir.
extent is important here, and you don't have to mention now skin and single nodular. That is
Yes, sir.
not. What is important is location first, then comes the extent. When you talk about that, you are written that is okay, 5 centimeter horizontal. So do you seriously think it's horizontal more or vertical more? See,
Sir, on
yes,
sir,
as we can see in the next picture. Can you show
yes,
the
sir.
next picture? Why it is becoming more prominent on the neck extension? Can you tell me, Dr. Vaibhavi?
Sir, this is a maneuver that is used for examination. It's known as Pizzello's method of examination.
No. I'm not trying to say that. Basically, Pizzello is for short neck. Okay.
Yes, sir.
If you look at this patient, he has got quite a significant
Long
length
neck,
of
sir.
neck. My question
Yes,
to you
sir.
is simple. This is a way in which what happens is, neck cervical lordosis happens. Lordosis.
Yes, sir. Yes, sir.
It causes a little bit of forward protrusion of the structures. That is the
Yes, sir.
reason why. And if you see this swelling, obviously we have not seen, or we have only seen picture. Do you feel its vertical extent more or horizontal? I may be wrong.
No, sir.
Yes.
In the image, it does appear to be vertical more than horizontal.
What is the usual thing happens in thyroid? Normally, vertical extent is more or horizontal lobes. If you look at logical, normal. Normal. Yes. Yes. Vaibhavi?
Normally, sir, there is a butterfly shape
Yeah, there is no confusion
of the
about
strand.
it. Okay, it is
Yes,
always
sir.
a vertical extent is much more than the horizontal. So
Yes, sir.
just be a little careful about this. Typically it's a vertical when the lobe gets enlarged. So it is
Yes, sir.
usual. It's a vertical extent is more than horizontal. Then comes your surface, then borders, then comes your skin over the swelling, etc., etc. Well, I think what most of things here. I just want to ask you one question, whether you mentioned or not, I don't know. What is that so-called the Adam's apple? As we are seeing the prominent cartilage, is it in the midline or you think it is shifted? Can you see that carefully?
Yes, sir. I can see the Adam's apple, sir. It appears to be a little shifted, but I palpated the.
No.
Yes, sir.
See. You need to have a careful inspection. We can also
Yes,
make
sir.
out that is an indirect reflection of the tracheal shift. You understand, no?
Yes, sir.
So
Yes,
if
sir.
there's obviously a right lobe, such a large lobe, you can see that. And I'm not sure there are some small swellings or something dilated. Prominent means, is it in the suprasternal space or chest wall? So we have written the Pemberton sign. What is this Pemberton sign? Can you tell me?
Sir, the Pemberton test or sign is a sign which is used to make out whether there is a retrosternal extension of the swelling. So
What do
in
you do
this
then?
sign, the patient is asked to raise both hands above their head for approximately 2 to 3 minutes. And then we observe the patient after that, and there is a flushing of the face which can be seen.
Facial edema, flushing, dilated veins, and you have to touch the ear actually. So when you don't see the lower border, it becomes significant. Okay.
Yes, sir.
You don't see the lower border. That too, in your case, you are seeing the lower border, correct?
Yes, sir.
And you are given a diagnosis, obviously benign. So I think that becomes irrelevant. If it is a malignancy, then there is some other people explain that it could be mediastinal nodes, etc. I think we are going a little away from that. So these are few things. These are my observation on inspection. Pulsations you have written, being little clear where you are seeing the pulsations. Okay, prominent pulsations. Okay, right. These are few comments. Sir. Thank you. Sir.
Vaibhavi, at one place you have mentioned the swelling is 4 by 6 centimeter, and other place you have mentioned the swelling is 6 by 4 centimeter. I think you should write only one point. It is,
yes, sir.
The first point is always the vertical extension, and the second numeric value is always the horizontal. So vertical.
Yes,
So
sir.
better to say it is on palpation. And don't use term approximate when you are doing palpation.
Palpation.
Palpation
Yes, sir.
means you need to be 100% sure that this is the confirmed finding. The size of the swelling is 6 by 4 centimeter in vertical and horizontal dimension. Okay, so you should be little bit careful about this thing.
Yes, sir.
Yeah, well, examiners may ask you one question. We haven't read the diagnosis yet, but still, looking
Yes,
at
sir.
your diagnosis, what you have written as thyroid cyst, that's what you have written. We'll come to that later, but you have written here firm consistency. I would ask you one question. What is thyroid paradox? Because you
Sir?
mentioned what is a thyroid paradox. Since you mentioned diagnosis is finally cyst, you have written cyst, correct?
Yes, sir.
And you are told firm consistency. Yes. Paradox. What is
Sir,
paradox?
in tumors,
Yes.
in tumors of the thyroid, those which have cellular
No. Let us not get complicated. You know, thyroid is deep to the what fascia?
so the pretracheal fissure.
So if there's a tense cyst, tense cyst, and
Yes, sir.
especially men with the strong neck muscles, men
Yes,
with
sir.
the comparatively strong neck muscles and deep to the pretracheal fascia, tense cyst may feel firm or hard. So that is what has been described as thyroid paradox.
Thyroid.
Because since having mentioned as a firm, and finally when they were given a cyst, they will ask you this question. Okay, right?
Yes, sir.
Yes, that's all.
Vaishnavi, you have mentioned that
Yes, sir.
Pemberton sign is test is negative.
Yes, sir.
What does it signifies?
Sir, Pemberton sign is
Hello.
hello. Hello. So Pemberton sign is used to evaluate retrosternal extension of the swelling.
Hello. Hello.
Hello.
Hello. Hello. Pemberton sign is to
Sir,
evaluate.
we are able to hear you, sir.
Sir.
Please go ahead with your question, sir.
So the
Hello.
Pemberton
Pemberton sign is.
So the Pemberton sign is used to denote a retrosternal extension of a thyroid swelling. It is because of the reduction of the.
Wait, please. In this case, what about the lower margin of the swelling is visible or not?
So in this case, the lower border of the swelling is visible, and the Pemberton sign is more significant in cases where the lower border cannot be palpated.
Lower border of the swelling is visible. In
Yes,
this
sir.
case, in your patient, lower border of the swelling is visible. Hai
Yes, sir.
Then there is need to mention that Pemberton sign is negative.
No, sir. It is more significant.
What is retrosternal goiter? Okay,
Yes, sir.
what are the types of retrosternal goiters between types of the what are the types of retrosternal goiter? This is commonly asked question for PG UG exam. That's why I'm asking you. Please keep in mind what are the types of retrosternal goiter and how will you clinically differentiate it?
So between types of retrosternal
Retrosternal goiter.
goiters. Um, so I'm sorry,
Okay, please keep in mind plunging, intrathoracic and mixed.
Yes, sir.
How will you differentiate this clinically? This is also one important point. And one more point I want to add on this. From where the intrathoracic goiter will get blood supply? What is blood supply of intrathoracic goiter? Retrosternal goiter? Please keep in this mind. Proceed.
Yes, sir.
Vaibhavi,
Yes, sir.
your description, it is clear that this is thyroid.
Yes, sir.
Okay. Now tell me about whether this patient is having, is there any thyrotoxicosis element is there?
Sir, at
There,
present, the patient,
then primary thyrotoxicosis or secondary thyrotoxicosis?
sir, at present, the patient, only based on the history, he had features of hyperthyroidism, but he did not as such have features of thyrotoxicosis. So the cardiovascular findings were normal. There was, at the time of examination, there was no tachycardia. There was no added heart sounds.
What happens?
So,
What happens in primary thyrotoxicosis?
sir,
Discuss one by one.
So primary thyrotoxicosis based on the organ system, or
No, what is the peculiar feature of the primary thyrotoxicosis on the basis of which we say that this is primary thyrotoxicosis, not the secondary one? Which system is mainly involved in the primary thyrotoxicosis?
so CNS involvement is
Yeah,
present, sir.
What happens?
So patient may present with irritability and emotional lability, and so exaggerated tendon reflexes and proximal muscular weakness.
And in the secondary thyrotoxicosis?
So there is a cardiovascular involvement, which the most common anomaly found is atrial fibrillation.
Okay. And in examination, on your physical examination, what is the pulse rate of your patient?
So on examination, the pulse rate of my patient was 88 beats per minute. So
88 beats.
yes, sir.
This was not the sleeping pulse rate. What is the meaning of this? Which one is more important, sleeping pulse rate or pulse rate?
Ideally, it is more important to do a sleeping pulse rate, especially in patients in which we want to rule out thyrotoxicosis.
I think Vaishnavi, the whole question which are asked because you have given a diagnosis and patient has got features of hyperthyroidism.
Hyperthyroidism.
So, but your diagnosis and this is not matching. So what I am trying to tell is, you have examined, no doubt. You have got a.
Yes, sir.
Have you completed your clinical presentation? Clinical.
Yes, sir. Yes, sir.
Palpation, all that is over. Have you?
Yes, sir.
Mentioned for anywhere tremors? See, you started with the when the question was asked, you mentioned about hyperreflexia, proximal myopathy, correct? But common things.
Yes, sir.
What is the complaint which they won't tell hyperreflexia? They will tell what? Tremors, correct?
Sir, tremors, sir.
Did you mention tremors?
So in the CNS examination, sir, I mentioned.
What did you mention in CNS examination?
So that there was no coarse tremors were present, so no coarse or fine tremors.
What you get coarse tremors or fine tremors?
The fine tremors.
So you have to be more clear here. No? See, when you have a case like this, common things you should do a general survey, quick general survey. Tachycardia, tremors to the tongue, tremors to the hand. Just see simple things. And you quick survey. Especially you have patient has got diarrhea, and in addition to diarrhea, weight loss, what is one strong complaint which you mentioned, which I thought primary? Yes.
So sleep disturbances, sir.
Insomnia. Particularly you have mentioned earlier there used to be a vein stress index. In that they used to give a very high and this insomnia. But we have not been able to explain later why insomnia and causes. So that is the reason why these questions have come. Because are we dealing with the two different pathology, or if we are asked to give one pathology, then what is the diagnosis? This is how it comes. Okay, right. These are some of my questions here. That's all.
Yes, sir.
You can go to the examination. Your examination, everything is over, I think.
Sir, I have a couple of.
Come to the final diagnosis.
Sir, I'm thinking the patient has a solitary thyroid nodule, most likely to be a benign.
How will you proceed further?
Sir, I would like to proceed with radiographic investigation, biochemical investigation, and an FNAC, sir.
Pardon? Which radiography?
Why did you keep a cyst as a diagnosis?
Sir, mistyped. I meant thyroid. Sir, I meant solitary thyroid nodule.
Yeah, not the cyst. So tell what
No,
are the
sir.
causes of the solitary thyroid nodule?
Sir, it could be a colloid nodule. It could be a follicular adenoma. So it could be a simple thyroid cyst, or even even a multi-nodular goiter can initially present as a solitary nodule, and on radiographic examination or ultrasonography, we can then differentiate.
Can it be malignancy also?
Yes, sir, it can also be a malignancy.
In the age of 68, again, I'm coming back to the age again.
Yes,
You're
sir.
68 years with a very
Yes,
short
sir.
history of 3 months or probably 6 months, which is there. It's a very short history
Yes,
for
sir.
the thyroid gland. So in this age group, with a very short history, you have to think first that are you dealing with a case of malignancy or not? Yeah?
Yes, sir.
Okay. So never think of the cyst in these patients. Cyst is usually just a very incidental finding it is found. Here is a big lump. It is a 6 centimeter size lump which is there.
Yes, sir.
68 years, so you do not think about that. You have to think about either it's a part of the multinodular goiter or it
Yes,
is
sir.
a malignancy which is there. Okay.
Yes, sir.
Go ahead with an investigation.
So for investigation, I would like to go for a radiographic imaging. Most commonly, I would like to go for an ultrasound of the thyroid gland. I would also like to do an FNAC, sir, of the gland, and so the biochemical markers, which would be thyroid profile with TSH, T3, and T4, sir.
What is a quadruple testing in the case of the thyroid swelling?
So quadruple testing is involves clinical history, clinical examination, the FNAC, radiographic imaging, and the FNAC, sir.
So it is only 3, isn't it?
And sir, and laboratory test.
What laboratory
Yes,
test?
sir. So
Laboratory
clinical
test?
detailed history, with a clinical examination, laboratory or biochemical testing, and an ultrasonography, and FNAC, sir.
Okay, what is the triple test in the case of the breast lump?
So triple test in a breast lump would be a clinical history and examination, and the imaging, which would be a mammography, and then so the biopsy, which would be an FNAC or a core biopsy.
Okay. So apart from those 3 in the triple
So
test, what is 4th in the quadruple test in thyroid?
Sir, the laboratory investigation, including the thyroid function test.
Laboratory. So do not say laboratory investigation.
Yes,
You
sir.
will say
The
the thyroid function test. No?
thyroid function test, sir.
Yeah. So clinical history and examination, then the thyroid function test, then the imaging, and fourth is the
Imaging.
cytology, right?
Yes, sir.
But some people say that thyroid function test is itself taken not as an extra thing, but you can do the fourth thing which is there is the some type of the genetic markers and all those things. So that is also some people say the quadruple testing which is there. But I think at your point it is okay that you say the thyroid function test is the fourth part of the quadruple test. Okay.
Yes, sir.
So in your patient, what do you expect the thyroid function test will be? And which one you
Sir,
like to do first?
Sir, in my patient, I expected to find, since the patient has clinical features of hyperthyroidism, I expected to find lower, reduced TSH with increased values of T3 and T4, sir.
Okay, if for the screening purpose, which test is done?
So first,
patient is looking at your thyroid and you just want to say that whether the patient is having any features of the toxicity or not. Which test you would do?
so we would do a free
Screening
T3. Yes, sir.
No. For screening, you would do the TSH.
For screening TSH, sir, and for the first presentation with symptoms of hyperthyroidism, we would do a free T3.
You will do the free T4 for that. No? If you
Yes,
want
sir.
to do for the diagnosis phase, the free T4. Okay, right.
Vaibhavi, you mentioned in your examination section the insignificant lymphadenopathy.
Sir,
In
I
which
said,
region? Anterior triangle or in the center of the neck or where lymphadenopathy, whether it is significant or insignificant, I don't get.
so there was no lymphadenopathy, sir.
No significant lymphadenopathy you mentioned probably, if I am not mistaken.
Yes, sir.
Okay. So there were no lymph node at all.
So no palpable lymph nodes.
Okay. Great. And ultrasound is also showing no lymph node.
So no, sir, there was no lymph node on the ultrasound.
Okay. So you have done ultrasound, you have done biochemical, your thyroid function test.
Yes, sir.
What next?
Sir, we can do radioactive iodine uptake.
What you have done in this case?
So so at present the patient is still under evaluation, but I would
Yes. What would you like to do further?
sir, I would like to do radioactive iodine scan.
Is there any role of thyroid antibodies? How many
Yes, sir.
different types of thyroid antibodies you know?
Sir, thyroid antibodies are anti-TPO, the anti-TPO antibodies. So there is the anti-EG, anti-TSH immunoglobulin, and sir, there is an anti-TG antibodies.
Okay.
So Vaibhavi,
Yes, sir.
yeah, when you told the investigations in the order, you mentioned,
Yes, sir.
especially in your case, FNAC you said earlier than T3, T4, TSH, if I am not wrong. Correct?
Yes, sir.
Is it the reason, any reason for that, or in your case especially, what is your order of investigations? She has come to the patient with this complaint to you.
Yes, sir. Sir, I would like to go for the thyroid function test as well as an FNAC in this patient. So
See,
based on the age.
No. Always, please remember in the examination, questions are very clear.
Yes,
Order
sir.
of she is in front of you. First thing,
Yes, sir.
what will you do in your patient? After that, what will you do? That's the order. Everything will be done ultimately, but that is not like that. FNAC will do first or thyroid hormones. You would like to see the report and then proceed. What is that you want to do?
Sir, I would like to go for an FNAC because it appears to be a solitary thyroid nodule.
Appearing can be deceptive. Always remember why we are having so many discussions, class, and all that thing. You said your patient has got insomnia, correct?
Yes, sir.
You said your patient has got what is subclinical thyrotoxicosis. It is also possible. Not that we are talking about thyrotoxicosis. You have to be very clear in your patient. She has diarrhea,
Yes,
she has weight loss, she has got insomnia.
Insomnia, sir.
It is better that you rule out, rule out. Sometimes these patients would have taken some tablets in periphery. We don't know. Your patient is very clear. It's a short duration. So,
yes, sir.
what is a safer approach is to get the hormones first, right? Then proceed with the ultrasound, and you should say ultrasound guided FNS, whatever it
yes,
is.
Sir.
That is what should be the order. Okay. Yes, that's all.
Valerie, as sir told, there must be an order that first biochemical T3, T4, then
Yes, sir.
ultrasound, and then followed by FNAC. What will happen if
Yes,
we
sir.
do the FNAC prior to the ultrasound? We can do that, na? We ask patient to come, send blood
Yes,
investigation,
sir.
pathology downstairs, and then go for FNAC because that is just next door. Ultrasound is not available. You can get it done after the day after tomorrow. Is there any disadvantage or I think before getting sonography if you do FNAC?
Sir, now it is preferred to do ultrasound guided
That is okay. That is
FNAC.
guided biopsy. That is guided FNAC. I am saying if FNAC is done and later on you are asking for sonography. Unguided FNAC has been done and then you ask for the sonography in the next step.
Sir, there could be hemorrhage, sir. There
Yes.
could be, if it is since it is on the more on the right side, it might have a, it might be a swelling which has a collection of blood, in which case there will be chances of hemorrhage, sir.
You may get means different report. What exactly it is, you are not getting the actual report. By doing FNAC, you are distorting the architecture in the form of bleeding or in the form of hematoma. Anything can happen. That will give
Yes,
you
sir.
false report actually of that
On
thing.
ultrasound.
That will be reflected on your sonography and the reports can be misinterpreted. So better not to, and it should always be guided.
Yes, sir.
And ultrasound followed by FNAC.
FNAC.
What next?
Sir, based on the findings of the FNAC, then we do, after that, we may plan the treatment modality for the patient based on the Bethesda classification. So, based on the Bethesda criteria, as this patient appears to present as a solitary thyroid nodule, it may be the management may be based on the FNAC findings. The first is if it is a non-diagnostic finding, then we do a repeat FNAC. If it is benign, it may either be a cyst or a colloid nodule. In cases of cysts, sir, we will do a simple aspiration, and this aspiration of the cyst can be repeated up to 3 times, after which we will have to go for surgical excision. Or sir, then the next is atypia of unknown significance, or AUS, or a follicular lesion of unknown significance, in which case we will go for a lobectomy in that case. It can also be a follicular neoplasm, or it can be suspicious for malignancy, or it can be malignant. And so based on that, we can further plan the patient.
So your final diagnosis is, tell us the final diagnosis so that we can move ahead.
So based on the ultrasound and the clinical history, my final diagnosis is sir, colloid nodule, sir, colloid goiter, sir.
Colloid goiter.
Sorry, sir, colloid nodule, sir.
Colloid nodule. Okay. So
Yes, sir.
is this solitary thyroid nodule?
Yes, sir, solitary thyroid nodule.
It's quite big. You don't think so?
It is quite large, sir.
The whole of the right lobe is involved. And you have ultrasound report in front of you.
Yes, sir.
Kanagabasok?
Yes, sir, I am with you, sir.
Yes, I am. You want to ask anything?
No, sir, no, sir. We'd like to ask for comments from that. I think if we are done, I think we can move on to the next case. We normally give the candidate to chance to ask doubts and other clarifications, sir. Dr. Vaibhavi, do you have any doubts to clarify?
Sir, not. I had, sir, a few doubts regarding, sir, the significance of, sir, the so the TIRAD's classification versus the Bethesda. Obviously, one is an ultrasonographic and one is the FNEC guide, FNEC based, sir. Sir, if there are not congruent, we will be giving preference to the FNEC, and the treatment will be proceeded based on that. And also, sir, there is one question that has been asked, is the difference between hyperthyroidism and thyrotoxicosis. There is no definitive answer that I've been found, but I have been asked this question before.
Yeah, I think one or two things from my side. The pattern of questions which will be asked is, I have not examined your patient, but my probable diagnosis should have been a solitary nodule rather than you specifically mentioned as a cyst and colloid cyst and all. That is because
Yes,
of the based on ultrasound you are giving a diagnosis. This
Yes,
type of mistakes should not happen in the university examination, because the examiners will immediately jump and say, oh, you have seen the ultrasound and you are giving a diagnosis.
Yes, sir.
When rest of the gland is not palpable, be safer and you say solitary nodule thyroid. What it can be in the thyroid settings. Yes, in the order of preference with the diarrhea in elderly people, we still would like short duration. Probably you are justified even if you give a malignancy, a diagnosis based on this symptom. But otherwise, in the science wise, you have nothing. You have nothing. So then adenoma. So it can be whatever be the variant, Arthur cell follicular, whatever it is. Then comes your solitary toxic nodule. There's one entity called a solitary toxic nodule, not necessarily Graves' disease. So solitary toxic nodule. That also can be matching, but even though your symptoms, gland, nothing is matching in this patient. Whether the diarrhea, all that thing is due to some other thing, which I cannot give explanation unless he has some other pathology. So in the order, it can be a solitary nodule in your patient, elderly, short duration, symptom of diarrhea. Maybe, sir, I may consider medullary carcinoma. Second is adenomas. Third is dominant nodule, toxic nodule. Then comes the largely cyst. So never put cyst as first diagnosis. After that, yes, the other your second part question, what is that use? Hyperthyroidism. Thyrotoxicosis is the manifestation. Like we say thyrotoxic ophthalmopathy. We don't say hyperthyroidism. These are all manifestations. T3, T4 levels are high, yes, hyperthyroidism. You can have a borderline, you can have a subclinical loss, but thyrotoxicosis means some effect has already happened. Organ, end organ. And this is what I feel so, sir. Other faculty, please.
Anything else, Dr. Vahid, baby?
No, sir. Thank you, sir.
Thank you. Hemant, sir, are you with us, sir? Dr. Hemant. Hemant,
Yes,
sir?
yes, sir. Yes, sir.
What is your comment, sir? Do you would like to add anything to it?
No, sir, it's okay. You have asked very good questions, and her mistakes have been caught. Like so that she does not repeat them in the exam. Like she gave a diagnosis of cyst because after the ultrasound, well, she had the ultrasound report. So as a resident, when you are present, even if you are given the reports, your diagnosis should be only clinical diagnosis. It should never include a ultrasound based report in your diagnosis. It is a good point, sir.
Thank you very much, sir. So, faculty, can we move on to the next case, please?
Sure, sir.
Yes, sir. Thank you very much. Dr. Vaipavi, you can stay back. Now,
Yes,
can I call up Dr. Deepak Agarwal?
Yes, sir. Good evening, sir.
But you can share your PowerPoint and start your presentation. I think you should sit little correct on your face is half cut in the screen. Yeah, that's now better. Good luck to you.
Thank you, sir.
Have any challenge, Dr. Deepak?
Yes, sir. The screen actually sharing, I'm not able to. It's stopping again.
Dr. Vaipavi? Dr. Vaipavi? You open this up. What is the problem now?
Sir, I'm sharing my screen, then I'm not able to see the PowerPoint presentation myself.
Who's there along with you, Dr. Deepak? Use your phone to start your presentation now.
Okay, sir.
Faculty, sorry for the delay. Dr. Vaibhavi, are you with us? Dr. Deepak, are you here?
On the phone also it is not coming.
Yes.
Sir. I'll just try and get back on with the laptop, sir.
No, we don't have time, Gana. You've been given adequate time. You cannot make everyone to wait. No, what's your difficulty? Just open the PPT in your phone.
Screen share. Yes, share screen. Start now.
Please, you can do that also.
I'm sorry, sir. This actually it was happening before. I'm not able to share. I don't know what happened. I'll
Yeah.
okay.
Connect well.
Yes, sir. Good evening, sir.
This is what happens when you allow these students to use their mobile without knowing what to do when things go wrong.
Sir, I did check, sir. He was able to play. Probably
I know,
next time
I know that,
Yes.
but he has to have backup, right?
I will ensure people have second backup also, sir. Not
Otherwise, you have it on your this presentation and keep it ready so that you can put it up.
let
This
me
is
try.
not the way it goes. See, there are senior professors.
I
can
understand, sir.
see.
I'm sorry, sir. These people are
The
tech wizards.
previous speaker is not responding to you. It looks as if she doesn't want to learn the next case.
I'm sorry, sir.
And when she was talking, there were sounds behind her. Somebody possibly washing utensils. or she was in a restaurant. I can tell you that much.
You start your presentation, Dr. Deepak. Deepak, are you with us?
Yeah, we can see the slide, Dr. Kanak will now.
Yes, sir. Yes, sir. I have made the slides from my device, sir. Dr. Deepak, can you start your presentation?
Oh, okay.
Only thing is, I should start presenting, I guess, sir.
So he is now seen.
Give me 1 minute. Dr. Deepak, are you with us?
Yes, sir. Yes, sir.
What is the difficulty?
So the screen share is happening, sir, but then
Okay,
I'm not.
when I'm talking when I'm showing my PowerPoint, you start your presentation.
Okay, sir. Okay, sir.
Remove this share screen now. Start presenting.
Yes, sir. Yes, sir. Sorry. Good evening, everyone. I'm Dr. Deepak from St. Isabel Hospital. I'll be presenting a case of mass in the abdomen under the guidance of Dr. Kanak. A patient, Mrs. Y, 84-year-old female residing in Chennai, homemaker. She presented with the chief complaints of loss of appetite for the past 3 months, nausea for 3 months, and vomiting for the past 2.5 months. History of presenting illness. Patient was apparently well 3 months back when she developed loss of appetite, which was insidious in onset and progressive. It was associated with nausea, which was aggravated after eating solid food. Later, it progressed to vomiting, which was non-projectile, non-bilious, containing eaten food particle. Initially, the frequency was 1 to 2 times per week, which has increased gradually to 4 to 5 times per week in the last 2 weeks. The vomiting is aggravated on taking solid food, but not to the liquid. There is history of dark or black color spotting in the vomitus on 2 to 3 episodes, but there's no history of frank bloody vomiting. The history of weight loss of 6 kg over the past 3 months. She has documented from 51 kgs to 45 kgs. There is history of chronic constipation, which was managed with laxatives. There's no history of black colored stools. There's no history of difficulty swallowing, abdomen pain, yellowish discoloration of skin. There's no history of fever, night sweats, cough, shortness of breath. There's no history of back pain or any bony pain. There's no history of similar episodes in the past. For treatment history, she has taken over-the-counter medications for nausea and vomiting with little to no relief in the symptoms. The patient went to a local hospital 2 weeks ago, where she was evaluated with upper GI endoscopy and biopsy, followed by a PET CT. Past medical history: she is a known case of hypertension for the past 15 years, and she's been maintained on medication. There's no history of surgery in the past. Family history: there's no history of cancer or cancer-related deaths in the family. There are 2 younger brothers who are alive and healthy. The personal history: she's married with 2 children, both of which were full-term normal vaginal delivery. She attained menopause at the age of 50 years. She's vegetarian by diet. There is no history of any habituations. Sleep pattern is normal, and she has normal bladder habits. To summarize, 84-year-old female with hypertension came with the complaints of progressive loss of appetite and nausea, vomiting for the past 3 months, with history of significant weight loss, with no other history of abdomen pain or constitutional symptoms.
Faculty?
Yes, sir.
Pradeep sir,
Yes,
Rajgopal sir. Yes, sir. Please, sir.
So, Dr. Deepak,
Yes, sir.
based
Yes,
on
sir.
the history, it looks like what is your organ of pathology? Looks like.
So probably the stomach, sir.
Okay. So, what are the what pathology you are suspecting on based on your history?
Sir, probably there is a partial gastric outlet obstruction which is causing these symptoms.
Why do you call this partial?
So because the vomiting is not after every meal, it's coming like in weekly. She's been telling about the vomiting, so some food particle might be passing through the like it's
What
not
would
the
happen if it is complete gastric outlet obstruction?
sir, she would have fullness, satiety would reach faster, and the vomiting would be there every time after food. Within some time, and that time could be progressively decreasing after food.
She is 84, I suppose. She is 84.
Yes, sir. Yes, sir.
So all these findings are most likely suggestive of which more likely malignant. I think
Yes.
you have covered all the points in your history.
Yes, sir.
Now come to the differential part.
Yes, sir.
What are the different causes of the gastric outlet? You said gastric outlet obstruction. What are the different?
Yes, sir. So there are benign and malignant. We can divide it into gastric outlet obstruction. So they can be mechanical obstruction and motility disorders causing gastric outlet obstruction. Mechanical obstructions can be benign or malignant. Benign, sir, most commonly there is peptic ulcer disease. Peptic ulcer disease can be there, sir. Then
how this peptic ulcer disease cause gastric outlet obstruction?
Sir,
we are presenting this case as a surgical case, no?
Yes, sir. So pyloric stenosis can occur after.
Then be specific.
Okay, sir. Sorry.
Be specific.
Yes, sir.
We have to focus only on your on this present case actually.
Yes, sir. Yes, sir. Pyloric stenosis.
Causes based on your history. What are the different causes of the gastric outlet obstruction? And you only told this partial gastric outlet obstruction. That's why I am asking these questions.
Yes, sir. So then,
apply your this common sense. Gastric outlet obstruction you told, na?
Yes, sir.
If something is there which is obstructing the stomach outlet is blocked.
Yes, sir.
I am asking the simple reason. What could be the pathology? It could be intraluminal, it could be intramural, it could be outside the. Give the common answer. This is normal, common questions, and I expect the normal, common answer.
Sir.
I am giving you a hint here.
Yes, sir. So intraluminal, sir, intramural, there can be obviously CA stomach, carcinoma stomach. Then, sir, extramural, they can be due to tuberculous lymph node. There is pressure on that. Then there can be due pancreatic head carcinoma, which is
Deepak, I will come in here.
Yes, sir.
You are telling us lot of things about distal D2 obstructions,
Yes, sir.
and you are telling us there is non-bilious vomiting. What is your explanation? So don't blurt out theory.
Okay, sir.
Look at a patient whom you are treating. This is a patient who has got non-bilious vomiting, is elderly, weight loss, CS stomach or gastric outer obstruction are obvious choice of diagnosis on history.
Yes, sir.
So why go into it? Now, in your history, again, you are telling some black spots or something like that you have said.
Yes,
What
sir.
does it mean to you?
So some
You are trying to extract that there has been bleeding from whatever the
yes,
lesion.
sir. Yes, sir. Some upper GI bleed. I was trying to find out if she is having.
Any ordinary patient, if you ask a direct question of black spots, is going to say yes.
Yes.
And then you go ahead saying that there is no melena. Tell me, what is definition of melena and how much blood should come into the stomach to go down to give you history of melena?
Melena is dark colored stools, sir.
Dark
Black
tarry
colored,
stools.
black colored.
They are known as tarry. You know what is tarry? What is tarry?
Like tar.
What is it? Tar. What is tar?
So it is like a sticky material.
No.
Tar.
Where do you
Tar
come
we use
from? Where do you
from the-
come from?
So West Bengal.
Chennai, right?
Yes, sir.
You come from Chennai, right?
Yes, sir.
How many potholes are there?
Yes, sir.
On what road?
Tar is used for making the road, sir. Yes, sir.
Tar. So what is that tar? What is that material? You don't know. It's okay. It's okay.
No, sir.
Go ahead. Go ahead. Let the other examiners come with the questions. Thank you.
Dr. Deepak sir asked how much quantity of blood is required to produce melena. Melena is nothing but the black tarry stool.
Yes, sir.
Totally black, but it happens because of the upper GI bleeding. And in your
Yes.
patient, the pathology, site of pathology is somewhere in the stomach,
Yes,
which
sir.
is blocking the outlet. That is why it is gastric
Yes, sir.
outer obstruction. That is why you are not getting a bilious vomiting.
Yes, sir.
Non-bilious vomiting, which is there, initially small in frequency, less in frequency, later on increasing in frequency.
Yes,
Okay.
sir.
So there is no doubt this is gastric outer obstruction.
Yes, sir.
But sir is asking how much quantity of blood is required to produce melena. A specific
sir.
question, very pertinent question.
Yes, sir. 50
First thing
ml.
you should know. First thing you should know what is melena,
Yes, sir.
how you will describe the melena, and
Yes.
how much quantity of blood is required to produce melena.
Yes, sir.
Melena is there, it means bleeding is where. You should know what
Yes,
should
sir.
be the site.
Yes,
See,
sir.
in your patient, the pathology is in the stomach.
Yes, sir.
Okay.
Yes, sir.
So you have to answer, na? You have to answer all these things.
So melena will come if there is 50 ml or more bleeding, then that
You're
can
wrong.
lead to.
You're wrong. It's 150 ml.
Okay, sir.
Now tell me, in the history,
Yes, sir.
this patient has been treated somewhere else, right? That's what you said.
Yes, sir. Diagnosed. Yes, sir.
Yeah. So what clinical examination notes that you would like to read, or if they are not there, ask the examining doctor as to know whether there is pure gastric outlet obstruction.
So,
Rajgopal, I think you should take over. Clinical examination of gastric outer obstruction. That's my question.
yes, sir. Sir, on clinical examinations, there will be a mass in the epigastric right hypochondrial region. Then succussion splash can be there, sir.
Okay, I will ask you this way. I wanted Rajgopal to come in because he's an excellent teacher. But now let me, since you said succussion splash, how do you do it?
So when we ask the patient to drink water, sir, and we listen through the shake.
You describe what you will do. I am your patient. I have taken water. I am with you, sitting in front of you. What will you ask me?
To shake. I'll shake the abdomen, sir, and then listen with the.
Hey, you will ask me to lie down or no?
Yes, sir.
So I'm lying down. You are going to ask me to shake my abdomen? What is your position?
So I'll be on the. You'll be supine. I'll be on the right side, sir.
Correct. Then what?
With
You
the
want me to
auscultation.
Auscultation. So you'll put stethoscope in your ears.
Yes, sir.
Where will you put the piece?
Sir, midway between the this epigastric and the xiphi-sternum and the umbilicus.
I'll ask you only last question. How many times have you done this?
No, sir.
Not at all.
No, sir.
Not at all.
Yes,
now
sir.
your patient, let's come to your patient. Have you sent this patient for examination and investigations before even looking at succussion splash? That's the end that I'm going to ask.
Yes, sir.
Okay. Yeah. Did you get the question?
No, sir.
So you are not done the clinical examination. Okay, I'll ask you one or two questions. Did you mention at least ball rolling movements? You know what is ball rolling movements?
Yes, sir. The patient will feel like the peristaltic movement in the stomach.
So this one question you have to ask. Secondly, you are telling 5 to 6 times per week vomiters, correct?
Yes, sir.
It is definitely persistent vomiting only. The reason is simple. They may not vomit today because the reason is stomach is
dilated.
So very often you get a dilated stomach. And
Yes,
one question to you, dilatation of the stomach is more prominent or more common, huge dilatation in benign disease or malignancy? There is some reason for asking this question. Say yes or no. We'll give you the answer. Don't worry.
No, sir. No, sir.
So benign disease is long-standing, correct? It's a
Yes.
long-standing disease. So, and malignancy is a short duration, and also there is some amount of infiltration happens along the antrum, or it may give a lesser curvature, greater curvature, etc. So not that you won't get dilatation. So this is one other thing you should realize. Okay. So
Yes, sir.
when there is a significant obstruction, the vomitous dilated stomach is there. So it's usually foul odor, previous day taken meal. This is typically described. Undigested food particle. This word should come. Did you
Yes, sir.
mention that? Undigested food particles? Because you written some
No.
blacks. That is why these questions were asked. So food contents, undigested food particle, which patient typically may tell, whatever I have written yesterday, with or without this ball rolling movements.
Yes, sir.
What is the mechanism that happens in a pyloric stenosis? What really happens there? And what really happens in carcinoma, which generally give total obstruction? This is another important question, because you have written here partial obstruction, correct? Some amount of liquid may still go down. Yes?
Yes, sir.
Can you come? Yes. What happens in a benign disease? There That's why, sir, Pradeep sir told you to talk full word and cicatrization. You know, cicatrization means really it become narrow. Cicatrized chronic duodenal ulcer, you know, post-bulbar or whatever it is. Here it is a proliferative lesion or a linitis. What is linitis plastica means?
Sir, diffuse stomach CA, sir. It is aggressive. And there is a leather bottle appearance.
Again, it can be local or localized or even so generalized. So whatever it is. So these are the one which gives rise to obstruction there. Some amount of liquid may still go down. So that is what you should try to explain here. Ball rolling sensation and all that thing. Okay. And another question is, yeah, that I think when we ask you in the examination. Okay. So that's also a few questions from my side now at present. You can go to, I think, general examination, sir. Is it okay, sir? Yeah, I think so. Can you go ahead?
Yes, sir. On general examination, patient was examined in a well-lit room after obtaining verbal consent in the presence of a female attendant. She was cooperative, conscious, and oriented to time, place, and person. Her BMI was 21.1. ECOG score was 0. Vitals, she was afebrile. Blood pressure was 130/82 mmHg. Pulse rate 84 beats per minute. Respiratory rate was 20 breaths per minute. Saturation, she was maintaining at 99% in the room air. Pallor was present. There was dark discoloration of the tongue was present. Other than rest of the oral hygiene was maintained. There was no icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema.
What do you mean by dark discoloration of tongue?
I also wanted to ask that question. Yes. What is that?
Actually, reddish, sir. Dark reddish.
So what is that? What is that red color or something?
Glossitis, sir. Glossitis.
Any angular cheilitis, etc.? Did you observe that?
No, sir. That was not there, sir. Not
bald. Was it bald due to anemia or something like that? Bald tongue.
Yes, sir. Yes, sir. It was very smooth, sir. Yes, sir. Like no papilla.
You should mention that. Okay, dark. So discoloration is not a word to be used here. We are interested to know, is it bald, anemic, and more importantly, any evidence of dehydration? You are not mentioned at all in your, if I'm not wrong, see all these things. You should mention.
Okay, sir.
Because
yes, sir.
why it's so important, no?
Yes, sir.
You can go for a week.
Rajgopal, I just want to ask him one question.
Yes, sir.
Okay. When you examine tongue of a patient,
yes, sir.
What are the things that you look for?
Correct.
Simple thing.
So color.
Okay. What does color tell you?
So pallor can be seen in
pallor. That. Stick to that. Don't answer too much. You get into trouble.
Okay, sir.
Color is one. Then?
Yes. So then the papillas are there. If any ulcer is present, if any...
1 minute. See, now you are only reading from the book. Rajgopal told you hydration. How does tongue tell you hydration?
Yes, sir. Hydration. Yes, sir. Dryness.
That is the second thing that you see. So one, you know whether patient is anemic. Second, whether well hydrated. These are the rules of the surgeon. Now you look at causes. Now in your patient, what are you looking at?
Sir, signs of anemia like pallor, if it is there.
Pallor, you will see on the tongue. Then?
So then any signs of vitamin deficiency, malnutrition like glossitis.
Your ultimate diagnosis is what?
Carcinoma stomach, sir.
Or chronic duodenal ulcer leading to pyloric stenosis.
Yes, sir. Yes.
So the next thing that you will be seeing in stomach is what?
in stomach.
Rajgopal, you take over.
Deepak, try to answer. Don't worry. If you don't know, say don't know. Somebody is prompting you, and you may land with the trouble also. Don't worry. Okay. Yes. Where are we now? So you have to, look for the evidence of dehydration, right?
Yes, sir. Yes, sir.
In pedal edema, did you mention what is the reason why you look for that?
So, pedal edema, sir,
Yeah,
it can occur if there is any renal involvement, renal insufficiency.
Why did you go to renal involvement? Means what? What is this? Yeah, it can occur, but in your case, patient has been vomiting, patient has got malignancy.
Sir, serum electrolyte levels will be low, sir.
Deepak,
Deepak, Chandra, Pradeep, you ask him.
Sir, please go ahead, sir. Sorry.
No, I'm just asking simple questions. Rajgopal is asking simple questions. He's gone through organ failure. What is the commonest cause of pedal edema in a malignancy patient?
You mentioned previously, dear.
Anemia.
You mentioned the
Anemia.
nutritional status, hydration status, and the performance status. You have to mention in each and every case like this.
Practice data.
We are not into 10, 20 points like this. You have to start like nutrition. What is the nutritional status of the patient? What is the hydrational status of the patient? And what is the performance status of the patient? The blood pressure, the pulse, and all these things are secondary things.
Okay.
The limiter. Pedal edema is there. Pedal, sir is asking specifically why this pedal edema. Pedal edema, you are going here and there. The most common cause is anemia. And you have already spoken about it. So what is the big deal? Hypoproteinemia, hypoalbuminemia, anemia, jo bhi bolo, but that can lead to pedal edema.
Yes.
You have to start from the very beginning. The most common thing you need to tell first, rather than cardiovascular and rather than renal and other causes, hundreds of other causes. We are not interested for those causes. We just want to learn only simple, single. One question, one answer, straightforward. Okay?
Okay, sir.
So slowly, Deepak, you have to develop this art of trying to, when a question is asked, how to explain icterus in carcinoma stomach. What is that you are looking for? Each and every pedal edema, lymphadenopathy, everything relate to your case. Then only you will understand the better about each disease. Okay, I think you can proceed.
Yeah, and I just want to say, let's say this is CS stomach without any comorbidities. Let us discuss.
Yes, sir.
How will you go about investigating this patient? You have done endoscopy, taken biopsy is positive for CS stomach.
Yes, sir.
Now what?
So then we'll try to stage the disease. We'll do endoscopic ultrasound can be done, sir. Then we can do a CT scan.
Abhidek. Endoscopic ultrasound. Describe endoscopic ultrasound. Don't talk of things in examinations which you don't know about. You have got a biopsy positive malignancy.
Yes, sir.
What is your next aim as a surgeon?
So to look for any lymph node metastasis.
Tell me the investigation that you would like to do.
CT scan, sir.
Okay. What are you looking at CT scan?
Sir, if in CT abdomen we can do, sir, in that we can.
We can नहीं. ये patient में क्या देख रहा है तू मेरे को बोल.
It's a local extent of the tumor.
Okay.
size.
Okay. Where are you looking at local extent of the tumor?
Like matlab adjacent organs to involving the
Adjacent
adjacent
organs is a general comment, boss.
the pancreas, duodenal.
Pancreas. Okay. One.
Duodenal extent, agar duodenal, if it is going.
Fair enough. So you have not told me what is the site of the tumor. Let's
Yes,
take it as around the head and the neck of pancreas, and you are answering these questions. Okay.
Yes, sir. Then, sir, the bile duct, if it is involving the bile duct.
Whom will you discuss this with?
Sorry, sir.
Whom will you discuss this with?
As so there should be a like full team, like multidisciplinary approach where
Okay, tell me what is multidisciplinary approach?
Multidisciplinary team, like the approach would be like different.
No. Don't tell me theory. See, you are only talking theory. When you go with this patient's CT scan, whom will you sit with and discuss the things?
So first, radiologist.
Okay. What will you ask the radiologist? What your areas of concern in CA pancreas? I'm not even getting to head, neck, etc.
Yes, sir.
What is your primary concern? Whether you can get it out or no. Correct or no?
Yes, sir. Operability. Yes,
absolutely. Sir. So tell me the structures you will prevent getting injured or not get into it. Will you discuss with the radiologist? Actually, this is a surgical gastroenterology question, not MS general surgery question. But I'm just still asking you. Just to make people realize that these sort of questions will come in. Go ahead.
So the surrounding major vessels are like portal vein, the aorta, if it is infiltrating.
No, aorta. No, see.
Okay, sir.
Where does aorta come?
So, like.
What is now? We come to basic question. What is portal triad? Rajgopal, take it.
Deepak, I just want to ask you, we are talking about the stomach. So what are the structures nearer to stomach? Is it a superior mesenteric vein? We are talking about stomach,
yes,
correct?
Yes, sir. Yes.
So what is that you are interested to ask the radiologist here? After the endoscopic, see, we haven't completed actual clinical examination, but we'll go to that. Yes. Very fairly advanced lesions. What are the things which you want information?
Sir, the extent, size, operability.
That's what I'm asking you. What is that?
So whether it is infiltrating this portal vein or there is any involvement of the pancreas.
Local infiltration, yes, it is possible. Pancreas, behind is the common bile duct, yes, possible. Yes.
Retroduodenal, if
then
it
you have
is
to do a more aggressive resections. So
yes,
large celiac nodes, yes. Then
yes,
nodes at the origin of left gastric artery.
Yes,
there are paralytic nodes. All those signs of inoperability you should know. Local yes, as well as local ear infiltration and adjacent structures.
Yes, sir.
In addition to this, what are the other information which even ultrasound can pick up? Metastasis.
So peritoneal involvement.
No. Peritoneum, how can even CT?
Liver metastasis.
Liver, paralytic nodes, etc. So
ascites can be there.
For peritoneal mets, which is the best one? Which nowadays,
PET,
you have to do in all belly.
PET CT, sir.
Anything. So diagnostic laparoscopy and proceed, correct? No, in all malignancies. So diagnostic laparoscopy, extensive peritoneal metastasis, no obstruction is definitely the case. Will go for chemotherapy, etc. Anyway, what are the signs which you have looked in this patient? Can we just move and quickly finish off signs? After that, we can take over because. Hello.
Yes, sir.
Okay, just tell me one or two signs. Where do you look for visible gastric peristalsis? Just tell me that sign.
So, from the left to the right, it will be there.
So
in this case.
Yes. So you have to, if you don't see, you have to stimulate that stomach by ask the patient to take some fluids, till he's really full and starts vomiting. It's very uncomfortable sometimes. And patiently you look and gently tap the upper abdomen. That's like a stimulation of the stomach. And you watch for the movement from left to right. Okay?
Okay.
Movement from left to right. So at that same time, you also look for lower border. That will give you some idea how the stomach is dilated or not.
Yes. Yes.
If you are given first the fluids, no point in doing succussion splash. So if you are the first candidate, do succussion splash first and then give the fluid to the patient for visible gastric peristalsis.
Okay.
I hope, right? So
yes.
I just want to know lastly, did you get the mass? Yeah, I
yes,
think you can just explain that. That's all.
Yes, on palpation, sir, there was a single palpable mass of approximately 6 × 9 centimeter, which was occupying the epigastric, umbilical, and the right hypochondrium. The borders were not very well defined. The mass was extending superiorly, approximately 6 centimeters above the umbilicus to the upper border of the umbilicus. And the breadth, it was extending approximately 6 centimeters the right side to the midline into the right hypochondrium, crossing the midline and approximately 3 centimeters towards the left of the midline in the epigastric region only. The mass was firm, smooth surface. It was non-tender, immobile, not moving with respiration. It became less prominent on head raising, leg raising. There's no pulsation felt or peristaltic movement felt. On percussion, there was dullness over the mass. The rest of the abdomen was sorry, one more point, sir. I was able to insinuate the fingers between the swelling and the costal margins. And the rest of the abdomen was unremarkable on palpation. There was no hepatomegaly. Spleen was not palpable. There was no expansile cough impulse over the hernial orifices. This diagrammatic representation. Now,
so show us the diagrammatic representation. Yes. Here you are saying your lump is in the right hypochondrium.
Yes, sir.
Where exactly this right hypochondrium lies? Can you divide the abdomen in 9 regions?
Yes, sir. 2 horizontal lines and 2 vertical lines. The 2 horizontal upper line is called the transpyloric line. It passes from the midpoint of umbilicus and xiphisternum at the midpoint. And
tell us in relation to the costal margin.
Costal margins are
transpyloric line passes through which point?
Tip of costal margin. It passes the tip of the this 11th. Ninth.
Now your lump is where? And the costal margin is this oblique line. What you are seeing is the costal margin, na?
No, sir. That is the side of the abdomen in the diagram.
What you have mentioned, the 2 upper, the folded
yes, sir, yes,
these are the costal margin, na?
Yes, sir. Yes, sir.
Costal margin.
Yes, sir.
Where exactly this 9th costal cartilage would come. So right hypochondrium would always be above that point, because that is the point where this costal margin is lying.
Okay, sir.
You have to divide the abdomen in the 9 regions, and the upper 2 vertical and 2 horizontal. The upper horizontal gives the transpyloric plane,
Yes, sir.
and the anteriorly to the tip of the 9 costal cartilage. But
Yes.
whatever what you have drawn here is quite below the hypochondrium region. Do you think this is hypochondrium? I don't think this is hypochondrium. Hypochondrium is just behind the costal margin.
Yes, sir. I also agree with you, sir, because it is the very smallest actually quadrant, hypochondrium.
Yes.
So picture, if we draw the picture lines, then it looks like it is below the hypochondrium. Okay.
Cannot you palpate only a very small segment of the hypochondrium.
Yes, very small.
Very small. The rest of the region is the umbilical and the lumbar and the right iliac fossa, whatever you have drawn. It is more in the lumbar region and the umbilical region and the epigastrium.
Yes.
This is my observation, because you have to be particular for all these things. It's well below the right hypochondrium. And the second point, you are saying that it is you are able to insinuate your finger between the costal margin and this tumor.
Yes.
So your area of concern, we have not examined, but your area of concern is in the epigastrium mainly.
Yes, sir.
May occupy the umbilical region.
Yes, sir.
Okay.
Yes, sir. Okay, sir.
Because this is 6 by 9 centimeter. It means 6 centimeter in the vertical dimension and 9 centimeter in the horizontal dimension. 6 by 9
Yes.
means 6
Yes,
in vertical and 9 in the horizontal.
Yes, sir.
Okay, na?
Yes, sir.
And this is in the pyloric region, so it must be somewhere in the midline, little off towards right side, you can say, or left side, depending upon your this thing. But I am not convinced with the right hypochondrium.
Okay, sir.
I may be wrong, but I am not convinced.
Yes. Okay, sir.
Because this picture, sir, it is almost looking like some problem is in the duodenum rather than
Yes.
it's moved to more towards the right side into the lumbar. Stomach is no doubt dilated. That's why you were having that extensive disease, large mass palpable. Okay, whatever it is. Yes. So, yes, proceed, I think, Deepak. Let's show that ultimately what are the other things which you look for evidence of metastasis in the abdomen other than this mass?
Sir, the umbilical area, there is no nodule or ulceration, sir. There are no skin changes, no peristaltic movement. That is like examination findings are not for the malignancy. No peristaltic movement, no scar, distension of the abdomen, fullness on inspection.
What we wanted to quickly tell you at this juncture is, sir, I look for nodular liver,
okay, sir.
umbilical nodule, ascites. Yes, younger patient, premenopause, like that you should tell. Okay. Yes.
The left supraclavian lymph node you should mention, because this is very important site that one should look for, especially in case of carcinoma stomach.
Yes, sir.
You should give separate sentence for the left supraclavian lymph node is not there. Okay.
Yes, sir.
What next?
So rectal. It was
rectal examination. What did you find?
So it was normal, sir. There was no. The rectum was empty. There was no stool staining, no blood, and there was no thickening of the pouch of Douglas.
Suppose some some metastatic deposit is there, then what are those deposits called as?
Sublunar shelf.
Okay. Okay, so you have confirmed the diagnosis. Diagnosis is confirmed. This is carcinoma, stomach. Okay.
Yes.
Now the second thing is to stage. You have
Yes, sir.
staged by doing the CT scan. Anything else you want to do apart from CT scan? Would you like to get non-contrast or contrast?
Sir, with contrast, sir.
Oral contrast or IV contrast?
Or oral plus IV contrast, sir.
What medication, what contrast agent you are using for your this thing?
So for oral, we are using gastrographin, sir.
And for IV?
IOX.
What only if you use only the IV, not oral?
So then we can know the blood supply of the tumor mass.
You will get the blood supply. Why not? You are giving IV. Everything is in bloodlines.
So the obstruction, level of obstruction, we can come to know if we give oral, but in IV we will not come to know whether it is completely or partially.
Sir, please go ahead. Rajgopal sir, Kanagabal sir, over to you.
Yeah, so what is your finding after the, so initially, how did you confirm the diagnosis?
So with upper GI endoscopy and biopsy.
Yeah, what is that common question? How do you prepare this patient? And how many pieces you take biopsy? What are the findings? As a PG, you should know that what are the findings which may tell you it could be malignancy.
Sir, ulcerative or ulceroproliferative lesion can be seen on endoscopy.
So in obstruction patient, better to put a nasogastric tube empty, otherwise he may aspirate during your scope itself.
Yes.
Okay, you have to take that no as a PG.
Okay.
You should mention that in the exam.
Okay,
so
sir.
there's a risk of aspiration, full dilated stomach, food particles are there. So yes, give a stomach wash, prepare the patient. Yes, ulcer, what else? Rugal folds, what is your common question? Rugal folds. Gastric rugae, what
Yes,
is your, what happens?
There is loss of rugae, sir. Gastric rugae.
Yes, converging and diverging. Okay,
Yes,
yes. Ulcer, then proliferative lesion,
Yes, sir.
friable tissue, bleeding, right?
Yes, sir. Yes,
Then,
sir.
if you don't see ulcer, scope is not going, it is giving some
Beyond. Yes.
pretty feeling like thing. What do you suspect? Yes?
Yes, sir.
Yes, you mentioned that we discussed little earlier. Ulcer is not seen, but the scope is not going, it's
Not
tough.
going beyond. Yes.
So what is that in the antrum? What variety it could be? Rhinitis plastica. Okay. So you may take biopsy and again biopsy on a biopsy like that, They say deep biopsies. Okay.
Yes, sir.
Right? Okay. So these are the few things which you will have to do and confirm the diagnosis. At least 8 to 10 pieces of a biopsy required to get a diagnosis. What is the common diagnosis you expect?
Adenocarcinoma, sir.
So read some Japanese and Borman classification and all.
Yes, sir.
Okay, I think that theory I hope you will read. Yeah, go ahead.
Yes.
What will you do now next? What you have done in patient? Tell the investigations and plan. Yeah.
So PET CT we had done, sir, to stage the disease, to look for all the metastasis. There were Mets, there were peritoneal Mets in the PET CT scan. Then there were multiple hypermetabolic, all the surrounding lymph nodes were, local lymph nodes were also involved. Lymph node metastasis was also there. So it was a advanced stage 4 M1 disease. So we'll go for a chemotherapy, palliative chemotherapy, and if obstructive, we can insert a self-expanding metallic stent to relieve the symptoms. It's a palliative treatment.
So your concern here is persistent vomiting is there and very advanced disease. So we have to have a nutritional buildup. You cannot just give chemotherapy for this patient. You told what you told is right, that stent or whatever. So
Yes.
then followed by, of course, improve her nutritional condition, and then
Yes, sir.
preoperative chemotherapy if patient is fit. This
Yes, sir.
obviously has to be discussed, and ejection fraction and other details. I don't know whether you have mentioned. You have mentioned only echo. So
Yes, sir.
cardiology and fitness, whether she is a candidate for chemotherapy. So then you proceed accordingly
Yes, sir.
for the treatment. Right?
Yes, sir.
Deepak, not like this patient. Your patient is quite advanced disease. What is the management of the gastric outlet obstruction? How will you prepare your patient with gastric outlet obstruction, irrespective of pathology?
So first we will be inserting Ryle's tube, decompressing the stomach. Then, sir, there'll be nutritional deficiencies will be there. So we'll have to take care of them, like vitamin deficiencies. We can give injections, inject IV vitamins, and the albumin, hypoalbuminemia, hypoproteinemia, they should be corrected.
Anything else?
More important, some electrolytes. What is that? What is that they develop? Persistent vomiting. What is that classical description mentioned?
Paradoxical.
Yes, that is the end stage. But start with the hyper, sodium, potassium, chloride,
Yes.
whatever. You have to, there is a flow chart actually.
Yes.
You have
Yes.
to follow that chart. Paradoxical aciduria is not the early stage. This is
Yes, sir.
something which is not, you should tell in the early phase. There is a sequence of events which are taking place. You have to learn all those events because those things are very important for everybody and especially for you because you have to undergo your final examination soon.
Yes, sir.
So electrolyte, this electrolyte imbalance and what is happening, there is a perfect flow chart. Just remember.
Okay, sir.
What is paradoxical aciduria you told?
So metabolic alkalosis with paradoxical aciduria.
What is the meaning of the paradoxical aciduria? How it happens? See, whatever you are telling in front of examiners, you should have a logical, concrete reason. Why are you? Otherwise, you please don't use, because in your case presentation, the maximum questions were asked only because of you. You have given lead. That's why questions were asked.
Okay, sir.
Okay.
Yes, sir.
Please don't do this. Otherwise, okay, you have to, you are doing good, but we focus on your case actually.
Yes.
Okay. Paradoxical aciduria, the electrolyte imbalance, the nutritional challenges, the hydration status. You have to build up the tone of the stomach. All these things are important, especially when patient is under your care and you are planning to do some intervention. Okay.
Yes, sir. Yes, sir.
So you have to build up all those things. You have to build up the patient as well as you have to build the stomach also.
Yes, sir.
Okay. Over to you, sir.
Hello. Hello.
Yes. Hello, sir. Yes, sir.
Dr. Deepak, one question, you said PET scan in the investigation, right?
Yes, sir. Yes,
What
sir.
what are the indications? Or you want to go for PET scan in each and every case of gastric carcinoma?
No, sir. First, we can evaluate with a CT scan. If it is showing some metastasis, like metastatic lesions, then we can go for a FDG full body PET to
So
see
then
whether
how it will help you?
if
If the CT scan is already showing that there is metastasis,
yes, sir.
then how
So
it will help?
doubtful, if it is doubtful whether
Yes,
the
it
lesion
has to
is
be doubtful, right?
yes,
And for small mets, peritoneal mets, CT is more sensitive, but
okay,
PET
sir.
scan is more specific. So for the locally advanced disease where you suspect there could be small mets, the distant parts not picked up by the CT,
Okay,
then
sir.
PET is more specific. But sensitivity of CT is more than PET scan. So every case does not deserve a PET scan in gastric carcinoma. Second, a question was asked, how you will build this patient? You said the case of metastasis.
Yes,
For
sir.
the nutritional, how you would build the nutritional status of the patient in this case. There is gastric outlet obstruction. The patient is having vomiting and all these things.
Yes, sir. Yes, sir.
So how you will build this patient?
So first, a hydration will correct with IV fluids.
Okay, no, but you cannot give build the nutrition by giving IV fluids. IV fluids are acute management of dehydration. It may take 15 days to build the patient for any further interventions. You cannot keep the patient on IV fluids or
Yes,
keep
sir.
the patient admitted in the hospital.
Yes, sir.
Or even if you want to go for the palliative procedure, then even you may have to wait for a few days to build the nutritional status of the patient. Otherwise, there could be more morbidity, post-operative complications. So what you will do in this case?
The TPN can be given.
You don't build the patient. TPN is for short duration when you want to give. No? Okay, partial TPN you want to say. कितने दिन दोगे TPN? 10 दिन 15 दिन TPN पे डाल के तो नहीं रखोगे patient को.
नहीं, sir.
And then TPN will start having its complications.
Yes, sir.
अभी तो इस patient में और क्या कर सकते हैं? What we can do to build the nutrition?
Sir, feeding jejunostomy कर सकते हैं.
Okay, one option is the feeding jejunostomy. What is better than that? Where you don't even have to go for the surgery.
Nasojejunal.
Very good. Nasojejunal tube. No, you can endoscopically guided. You can place a nasojejunal tube and give a high protein, high calorie diet to the patient.
Yes.
And later on, then you have built the nutrition of the patient. Then
we can place
the malignancy was on the anterior wall or on the posterior wall. What was the location on endoscopy?
Body of the stomach. On endoscopy, this much only was reported, sir.
No, it was body of the stomach. Where? Anterior wall, posterior wall.
Not reported.
Lesser curvature near the greater curvature. Where it was?
Greater curvature.
Greater curvature. So what you can do? What palliative procedure you can do? You said it's already a case of metastasis. Huh?
Yes,
so
sir.
Chemotherapy is not going to do much good for the patient. Gastrectomy will also not solve the problem.
Yes, sir.
Only if it is bleeding, then only you can go for the palliative gastrectomy. But for this patient, it's going to be a big procedure with a lot of perioperative complications. So if it is not bleeding, you have stopped the bleeding. What you will do to stop the bleeding, and what palliative procedure you will do for this patient?
The gastrojejunostomy.
Gastrojejunostomy later on. Yes. So the patient can have meals without vomiting. So you will be palliating the vomiting, and patient will be having the nutrition till he survives, whatever is few months of survival is there. And for the bleeding, what you can do?
Sir, radiotherapy. Radiotherapy
can be tried. More simple things.
Sir, endoscopic, like we can.
It is raw. It is ulcer which is bleeding. No? It is endoscopically. Kya karoge?
Sir, octreotide injection, sclerosing.
It's a big ulcer you are saying. That is for duodenal ulcer. That is specific. Yeah. Because simply PPIs. PPIs Antacids and antibiotics, they can relieve, early malignant ulcer, they respond to PPIs very well. Proton pump inhibitors. So you can put the patient on these drugs, even a course of antibiotic, because there's infection sometimes at the of the malignant ulcer, and that leads to its more friability and bleeding from that side. So these things can solve the problem. Or then other option is the palliative gastrectomy to control the bleeding. Radiotherapy, it has a limited role. Yes, it can be tried if they can do. I don't know what is the recent guidelines. So you have to manage the patient according to these guidelines. Okay.
Okay, sir.
What do you, sir?
Sir, any other faculty would like to have comments, sir?
Sir,
Madam, please. Good evening.
Sir, they have discussed almost everything, but I just want to know from him that what is the line of chemotherapy he will offer to this patient? What type of chemotherapy? What is the chemotherapeutic agent he will offer to this patient?
Sir, ma'am, 5-fluorouracil, adriamycin, and mitomycin C. We can give.
Is the newer?
So, sorry, ma'am.
Initially, you used to give that one. Nowadays?
Epirubicin, oxaliplatin, capecitabine, taxanes.
ECF.
ECF. Okay.
But your patient age is 84 years, no?
Yes, ma'am.
So 84 years, most of the time they won't be willing for any or any major intervention. They want to live a peaceful life till their end of their life. So what will be your optional line of management in that patient life? Just to improve quality of life in order to have some amount of food or something.
Trastuzumab can be given, ma'am. Like if they're ready for procedure, I will ask them to get a self-expanding metallic stent to be placed.
That will be the minimally invasive and it can also prevent the wound. Huh?
Yes.
Okay. 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 So over to you, sir.
Thank you, madam. Thank you. Kanna sir, I think, has left. Rajgopal sir, would you like to add anything, sir? Hemant sir, Pradeep sir?
No, sir. Thank you.
No, sir. Thank you.
Yeah, I think it should be clear about because this is a very common long case and upper abdominal mass. So carcinoma stomach, you should not have any confusion about the mass, details, causes, common differential, like some signs which have been asked to you, then the investigations, etc. Okay.
Ishwar sir, would you like to add anything, sir? Good evening, sir.
Sir, namaskar.
Namaskar, sir.
Good evening, sir.
Good evening, sir. Good evening, sir.
Just I was listening to sir, some other work.
Yes, sir. Yes, sir. Yes, sir. Faculty, other faculty, can we call a close?
Yes.
Questions here?
Yes, sir.
Okay. Good night, sir. Good night, everybody. Thank you, sir.
Good night, everyone. Thank you, sir.
Thank you.